challenges affecting the overall adoption of autologous T-cell therapies. Dr. Sassine, could you share your perspective on the top challenges with autologous T-cell therapies today?
Sure, there are a few. So, in my view, the biggest challenge that we have is getting the right patient to the right therapy. And right now, most of the patients who, I think most patients most of the time could get these cell therapies. We commonly treat people who have comorbid illnesses, patients who are elderly, and even in their 80s, successfully so. But many of these patients are just never referred to the authorized treatment centers. And so I think educating the community about these novel cell therapies and, number one, why they're so important, how much benefit they can provide to patients. Number two, yes, they have toxicity, but this toxicity is usually manageable with the right standard of care, moderate immunosuppression if need be, and supportive care. And number three, that they should be very liberal in referring these patients to us so that we can go over the pros and cons with them. I think that would be the thing that most impacts the access to this new technology. But there are other barriers, and maybe we'll go into this more in detail later on, but the toxicity is certainly a barrier, even though, like I said, it's usually manageable. It's certainly unattractive, and if there's an alternative therapy, sometimes there's a long discussion about what the next best step would be on the basis of that therapy toxicity profile. The other challenge is, of course, the logistics. So this is not something that is easily done. It's not something that can be done by the average physician or hematologist or oncologist. And even in a specialized center, it's quite complicated. It's time consuming, it's expensive. And when all is said and done, sometimes it doesn't even work out with usable cells. So there are many challenges to go through, some of which can be addressed by the new technologies. Some remain challenging.
Thank you, Dr. Sassine. You said the complicated process, the logistics. Tell us a little bit more about that.
Sure. So when a patient comes to see me in clinic and they look preliminarily like a good candidate for CAR T cells, we would love to be able to just do it. But unlike many of our other types of therapies, it's not something that you can do for both biological reasons, but also logistical and regulatory. And so when a person is first identified as a potential CAR T candidate, we usually move to do multiple things in parallel. So for example, we start screening them if they need some procedures to make sure that they're medically fit, and almost all patients would at that point. If they would also need financial clearance. They would need to start identifying a caregiver for their post-treatment course. Often they would need to identify lodging, because after the infusion of cells, they are going to need to stay near the authorized treatment center for at least the first month after treatment. So all of these things are happening in parallel. And then when we've determined that they are an appropriate candidate, and both medically and socially and through all of those other loose ends are tied up, then we can take their cells via the leukapheresis procedure. But it still takes at least 2 weeks or so, usually more. Sometimes it's 4 or 5 weeks before we actually get the cells manufactured. And then we coordinate bringing them back to the center for the conditioning, chemotherapy, the infusion of the cells. It's often done, almost always, in the hospital. And after they're discharged, they would need to go to their prearranged lodging to stay with their caregiver for that first month.